Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Dr. Ro'a, for the kind introduction as well as invitation. It's my pleasure to be speaking at this session with pioneers in the field and taking you away a little bit from the rheumatological diseases to something that actually shares with us with both of our specialty. I can assure you that when I see patients from rheumatologists coming to my clinic with osteoporosis, I feel so happy because at least I can tell you that these patients are taking calcium and vitamin D when they present to my clinic. Other than rheumatological specialty, my patients with osteoporosis actually, most of them already started on anti-resorptive therapy without even taking calcium and vitamin D. So to move the slides, is it this right side or the left side, the slides? The bigger one, okay. All right, thank you. These are my disclosures, and I do not have anything, conflict of interest of my lecture today here. And in the next 20 minutes, inshallah, if not sooner, I'll be going very briefly about the risk factors associated with the glucocorticoids, pathophysiology, management strategies according to the available guidelines, and briefly we'll touch base on the Saudi FRAC score that was recently developed by the group. So if we start with the case, and after I saw your lectures today, I'm pretty sure you're not seeing such patients, but I didn't know how advanced rheumatology has become. But bear with me for a second, and this is a 62-year-old female with rheumatoid arthritis diagnosed at the age of 50, had lumbar fixation. She told me that she might have had a vertebral fracture. She's a smoker. She said that her rheumatoid arthritis is fairly controlled and does not do any exercise at home. She's been on prednisone 5 milligrams for 11 years. She's diabetic, pre-diabetic, hypertensive, hyperlipidemic. She is not on any calcium or vitamin D. I'm pretty sure you're not seeing such patients anymore after I saw your lectures and the advancements in the field of rheumatology. So on evaluation, she had basically not bad normal labs, slightly anemic, had an A1C of 6%. She had slightly lower calcium and a vitamin D level of 14, which is deficient. And I'm sorry if you cannot see this, but her T-score on lumbar spine was around minus 3.1, and the femoral neck was around minus 2.3. So if we think about this patient, regardless if she has rheumatoid or not, regardless she's taking the prednisone or not, she is an osteoporotic patient that needs to be treated. But given that she is on a dose of steroids and she's been on that for like 11 years or more, I think we need to, there's one more higher factor that we really need to consider treatment for osteoporosis in her. So steroids-induced osteoporosis has been described 80 years ago. In adult population, at least 1% of all adults or 3% of those who are more than 50 actually take corticosteroids for different reasons. And the most common fracture that is associated with the steroid-induced osteoporosis is actually vertebral fracture, and the risk increases within the first 3 months after the initiation of treatment. And actually, the risk will not only increase just with the duration, but also the risk increases with the higher doses of steroids, increases the risk of the fractures by more than 50%. So those who are being treated with 2.5 milligram will be at less risk of fracture compared to those who are being treated with 7.5 milligram of prednisolone daily. And the other problem we face, I believe you face the same, that the physician awareness of the glucocorticoid-induced osteoporosis is a major barrier. And unfortunately, that this is something that we face, that patients usually come to the clinic and show up in the spine surgery clinic or the orthopedic clinic already have had the fractures just that could have been very simply prevented. So if we think about the risk factors related to the glucocorticoid use, having osteoporosis, can be divided into 3 categories. It can be because of the glucocorticoid use, depending on the dose and duration. And we should not forget that the steroids also increase risk of myopathy, that can increase the risk of falls. It can be related to the underlying condition itself, either rheumatological or non-rheumatological. It can be related to the osteoporosis itself. So if we go back to our patient, she's more than 60, she is a female, she's a smoker, she has a lower BMI. So the risk factors for osteoporosis itself, regardless of what kind of other diagnosis this patient carries, increases risk of osteoporosis. So in terms of the pathophysiology, the steroids can increase the risk of osteoporosis based on the cellular and at molecular mechanism and extra muscular effect. And basically what happens is when patients take steroids, there is a cascade. I'm not going to take you, because we endocrinologists like to go into details of this cascade, but what happens is basically one of the nuclear receptor expression of rank ligand increases, that will increase the number of osteoclasts, which basically goes into imbalance with the osteoblast, and that will increase the apoptosis, and that will increase risk of the osteoporosis in such patients. Other than factors that are at the cellular level, patients would also will have decrease in the calcium reabsorption at the kidney level, and there will be problem in terms of their muscle and connective tissue because of the myopathy, and also such patients will have steroids can cause decrease in the sex and growth hormone, which are extremely important for the anabolic part to prevent osteoporosis. What's also noticed that patients who are taking steroids, they are at increased risk of the trabecular bones, vertebral bodies that are like more fractures in the vertebral column compared to the cortical components of the long bones. So in terms of the guidelines specifically made for the steroid-induced osteoporosis, there are many guidelines by national societies, and actually American College of Rheumatology were among the first societies who actually endorsed such guidelines, initially developed in 2010, and then they had it in 2017. As far as I understand, they will have another one updated at the end of 2022. And these guidelines, apologize for the not showing, but I'm going to show this. They're stating that it's very beautifully written and clearly divided, that they divided the subject in terms of the risk by two groups, those who are of age of more than 40, those who are of age less than 40. And in terms of the glucocorticoid status, are those patients actually initiating the glucocorticoid therapy versus those who are continuing the glucocorticoid therapy, as well as the risk of fracture based on the FRAX score, is it like low, medium, or high risk? So the goal of the evaluation, they're saying that they need to catch up patients who are at high risk of fractures, and initial clinical fracture risk assessment should be performed at least within 6 months of initiation of the glucocorticoid therapy. And any patients who is taking the dose of glucocorticoid therapy and anticipated that he's going to continue that for at least more than 3 months, they should be evaluated. And of course, other factors needs to be ruled out, like the secondary causes of osteoporosis. Adults who are more than 40 years taking any dose of steroids more than 3 months, they should be evaluated with a bone mineral density scan. Adults who are less than 40 years, if they are taking high doses, for example, 30 milligram or more, for at least more than 1 month, or more than 5 milligram for more than 1 year, they should be also evaluated using a BMD scan. In terms of the FRAX score, these all are the different factors that needs to be taken into consideration apart from the T-score that is we can find it on the BMD. And as you can see on the last one on the left side is the glucocorticoid use. Unfortunately, the FRAX score does not take into the account the dose, the duration, or the anticipated how long the patient is going to be on the steroids. So the FRAX can be used for patients without established osteoporosis, for example, patients who have osteopenia, those who have a T-score that's less than or equal to minus 2.5. And it estimates the 10-year probability of fractures between the age of 40 to 90 using a femoral neck BMD along with the clinical risk factors. And as I mentioned, it does not take into the consideration the duration or the dose of steroids. And with the FRAX scale, they actually divide the patients into different categories: low, moderate, and high risk of fractures. And of course, those patients who are, once we come up with the score, those patients who are at high risk, they will definitely gonna benefit from treatment on long term. And once we start talking about treatment, as we are talking about, for example, when we discuss the treatment of type 2 diabetes, I think lifestyle and risk factors are extremely important. Smoking cessation, weight-bearing exercise, taking their supplementation of their calcium and vitamin D, and making sure that the compliance is a big issue. As my colleague said, in our country, we have patients who are not compliant with their medication, and patients are thinking if they start taking their alendronate once weekly is much easier than taking calcium and vitamin D on a daily basis. I think these kind of factors needs to be really discussed with our patients in details. Having a bone model in your clinic, and I'm pretty sure you all have that, might help to explain to the patient the pathophysiology and how important it is to take their vitamins and calcium on a daily basis. Weight-bearing exercise, I'm pretty sure you do refer a lot of your patients to the physiotherapy. Weight-bearing exercise, actually, they are simple, can be done at home, and like just simply giving the patient a piece of paper where actually they have the drawings or the pictures of simple things that can use, they can get it at home at least for 20, 30 minutes, along with the walking will be a good way to start. What about the recommendations for the calcium and vitamin D? The patients needs to be at least on vitamin D 600 to 800 international units, and as well as of calcium 1 to 1.2 grams per day. And in terms of the treatment, usually continuing the calcium and vitamin D, and then if the patient requires treatment, usually start them with either of one of those three options, which I'm pretty sure you all know, either the bisphosphonate or the anabolic hormone teriparatide, or the third one, which is the denosumab. So for the bisphosphonate, we have the oral or the IV, and any of those can be used. Is it one better than the other? It really depends on your patients. For the bisphosphonate, has been Cochrane reviews and randomized controlled trials actually has shown benefit. We have at least 12 randomized controlled trials, and that was back a year ago. At least 1,400 patients were involved, and actually it has shown that it has decreased the risk of the new vertebral fractures by 43%, and the number needed to treat was around 31. And as you can see, different forms of bisphosphonate, actually most of them have shown in those patients who are, and these are patients with glucocorticoid-induced osteoporosis, not just the regular osteoporotic patient. They've shown that they benefit in terms of reducing the new vertebral fractures. In terms of the teriparatide, which is an anabolic hormone, it was associated with greater increase in the bone marrow density in the spine compared to the alendronate, but that was only radiographic evidence, not actual fracture. And there was no significant difference in terms of the two treatment groups comparing the teriparatide versus the alendronate over 36 months in terms of the rates of the non-vertebral fracture, but the radiological rate was lower. Denosumab, and I'm pretty sure you have already started using that, also is a great option. It has shown superiority in response to the increase in bone mineral density at 12 months. And the other one, which I did not bring it in my slide, is the actually raloxifene is also a good option if the patient can tolerate the side effects. So in terms of the recommendations quickly, it's very important to optimize the calcium and vitamin D. Once we calculate the patient's FRAX score, and if the patient does not have fracture, patient is high risk, we should start them on some sort of treatment. And in terms of the duration of treatment, we usually continue while the patient is already on steroids, and I'm pretty sure with this new advancement in your treatment, the patients will be taken off steroids, and that will be easier to manage their osteoporosis. Following up, I do see a lot of patients having BMD scans every couple of months, and they are having it in different hospitals, and that's not really helpful. What we recommend the BMD scan to be done in the same hospital, same setting, if preferably possible by the same technician with the same machine, and it has to be repeated at least 2 years after starting the treatment. And then we follow up the treatment to see if we are going to discontinue or give them a holiday, or should we add another medication for the osteoporosis. And like any other chronic disease, we do have barriers that patients are actually not following, and we are very easy to blame patients. And I think we have to take our role to educate our physicians. The physicians are not aware of the risk factors. They're not aware of the disease. Patients already are showing up in the orthopedic clinic with fractures, and the orthopedics are the one who are starting the treatment. The patients are not continuing the treatment. These are medications that needs to be taken for long term, and some follow-up needed to be done in between. And we need to confirm that. And I think there is a role of us as a physician to improve the awareness in the society along with the other chronic medical condition. And of course, back to our patients, we started her on the calcium and vitamin D, referred her for the weight-bearing exercise, and then we started her also on the alendronate 70 milligram. And I usually, in my practice, I do that not immediately at the same time when I start the calcium and vitamin D. We usually do that like 3 months later after confirming the patient is already taking the calcium and vitamin D. And then we of course, repeat her BMD scan in 2 years. So briefly, for the last few minutes, in terms of the osteoporosis data in Saudi Arabia, as you can see, we do have the risk of or incidence of the hip fractures. It's around 100 in the best of the data available per 100,000. And a group in the National Guard Hospital in Riyadh with other hospitals in the region, they started collecting data. This was a SAFE project covering over 2 years data from 2017 and 18, and around 15 hospitals actually that admit and operate on patients with hip fractures were included. And retrospectively, they continued, like they actually reviewed the patients who were included in the, like diagnosed or the osteoporotic hip fracture. And they compared the data they had with the neighboring countries because they were trying to develop the FRAX that is specific for the Saudi Arabian region, which was actually developed already back in November 2021. And as you can see, this is the annual incidence rate of the hip fracture in Saudi Arabia. You can see the separation of the curve between the men and women that happens at the age of around 58 or 57. And that is to say also that the men also at risk of osteoporosis once they are older. We only look at the women, but I think this is something that we need to consider while we are treating patients. So this is the paper for the application of FRAX in Saudi Arabia. The actual risk score paper is under publication. So what we have learned that glucocorticoids are being used very commonly. They can increase the risk of bone resorption, and over a short period of time, not even on that they are not only if they are being used for a long period of time. And those patients should be seen either rheumatologists or endocrinologists and should be evaluated from time to time. And the patient should be started on calcium and vitamin D. And we usually recommend or prefer to start with the once weekly bisphosphonate, but individualization is a must, whatever is easier for our patient. Thank you for giving me the chance again. This is my email if you have any questions. Thank you.